Thursday, everybody. Yes, we're starting on time. There's too much bubbling excitement. I suffered from CP Solver's withdrawal. It was life-threatening, as I shared with the team in an internal session. And yes, one other reason to join the CP Solvers Academy by presenting your cases is to hear a lot about my personal life drama, which may be more repelling than it is alluring, but I will leave that for you to decide. But I have three reasons to be very happy today. The first is that I finally get to come back and hang out with you all after missing 1 week, 1 whole week, 7 days. I survived. Um, but today's very special because I finally get to do round two of discussion with the one and only Julia. And you might have asked what took me so long. The answer is I don't know. Julia has been crushing it in the CP Solvers realm, despite having maybe 3 or 4 full-time jobs, one of which includes applying for this year's match. The other includes her probably her actual job uh, as a researcher in the U.S., not currently where she is. Um, but also just continuing to crush it in the CP solver space by being an ever present member in every single domain. So I'm very, very excited to discuss with you, Julia. And I'll hand the mic to you to say hello, and then we can introduce the other exciting aspect of this session today.
Hello, everyone. It's a pleasure to be here in this community, especially discussing another case with you, Robbie. I'm very, very happy to be here, and I'm so glad of all everything that you presented. And yeah, this I'm very, very glad. Thank you so much for the presentation.
Yeah, I think we have a tough job because the case presenter is somebody that you all may know less than I do. Riku is joining us from Japan at 11 p.m. I've known Riku more than I've known most people here. We worked together, first met 3 years ago, I believe, when I went to visit him and his colleagues during his intern year in Japan. And Riku stood out in his interest and passion for clinical reasoning a long, long time ago. Uh, if it weren't for the time zone differences, I think you all would know Riku a whole lot better than you currently do. So let me hand the mic to him to introduce himself. Very, very excited for your case today, Riku.
Hi, thank you for nice introduction. And I was so looking forward to work with this session with Rabih, and I'm really happy to have like been here. Thank you.
Very, very happy to have you, my friend. It's a shame that the for most of this session you'll be hearing the three of our voices, Julia, Riku, and mine, but it wouldn't be happening without two people, Manaswini and Aaron. Let's do it alphabetically. Aaron, mic to you, and then to Manaswini.
Hey everyone, I'm Aaron doing teaching points today. Excited for Rico's case.
Hi everyone, I'm Manuswini, excited for Rico's case and Julia's discussion.
All right, guys, let's rock and roll. Kudos to you, YouTube audience. You only had to survive 3 minutes today. All right, Riku, we've been waiting for a long time. Take it away. We're ready whenever you are.
Okay. So let me start with Alco 1. So 21-year-old female presented with fever, painful swallowing, bilateral ankle swelling. Painful swallowing and
Hmm.
bilateral ankle swelling. And
Wow.
I stop there.
That's a very hard aliquot to say. Painful swallowing and bilateral ankle swelling. But hard to say, Julia, but also hard to think about. What are you thinking with this interesting start?
Yeah, first starting with the fever and painful swallowing, trying to connect both of symptoms. The first thing that I will think about is infection. So I will think about upper respiratory infections, most commonly one viral disease such as COVID or influenza, because when you have a viral upper respiratory infection, you can have fever, painful swelling because of swelling of the tonsils or every inflammation that you have in the tonsils or your oral cavity. But thinking about the bilateral ankle swelling, I'm not sure how to connect this with the fever and painful swallowing. Maybe this is just something else that is going on, not part of the actual symptoms, or maybe this is like a consequence of inflammation, systemic inflammation that can be going on. But for now, that's my first thought. I was thinking also about inflammatory diseases, and yeah, I think that that's it. What about you, Robbie?
Yeah, I'm right there with you. I think, the very fact that the patient has symptoms from head to toe, literally, and that she has a systemic sign, a fever, probably reframes this case as a systemic issue. And the question really is, how do we make progress with the localizing clues that she's giving us? And I think whenever you have painful swallowing, you know that there's a very high chance you will see a specific structure involved in the oropharynx. And the problem will be clarified much more by understanding which structure is it involved. For example, does she have an oral ulcer? Does she have pharyngitis? Or, counter to the base rate, does she have large lymphadenopathy that's causing her inability to swallow? And so I would share a piece of advice with everybody that most of us probably assume that her difficulty swallowing is an internal problem. And that's what it is, statistically speaking, but it might as well be something external too. And the same goes for the ankle, because what the patient could have said was leg or toe. The fact that she's saying ankle makes our mind subconsciously assume that she has an arthritis. But she could easily just have soft tissue edema and that she has uh, a volume overload rather than an arthritis. So I think what you can confidently say is one, based on what we know now, there is no need for any treatment. So we proceed with further diagnostic hypotheses. And the major progress will be to translate these symptoms into specific structural uh, compromise and be able to make progress based on that. So I'm right there with you. I think the only emergent issue could be that her difficulty swallowing represents a potential airway risk. And I think making sure that it doesn't is going to be really, really crucial to make sure that we can continue to proceed without any therapeutic interventions. All right, Rico, mic to you.
Wow. Thank you. So I go next. Our HPI, 4 days prior to presentation, she developed painful swallowing and white patches on her throat. And 2 days prior to the presentation, she developed pain in the left ankle, followed by right ankle pain, progressively worsened, which prompted her to come to the ED. So, she reported to have difficulty walking due to ankle pain, and she was using a wheelchair to use the bathroom in the hospital. So she also has a spot-like rash on bilateral legs, no itching, and no recent exposure to sick contact. So about the review of symptoms, she had myalgia, no headache, no vomiting, no nausea, no diarrhea, and no other review of symptoms are negative. And past medical history, she had Osgood-Schlatter disease at the age of 15, and she had allergies for ibuprofen, and she took no medication. And her travel history was she traveled to India and Cambodia 3 months ago. And her sexual history, she was sexually active with one male partner, and her family history not significant, and her menstrual history, regular menstrual floor, and her social history, no history of drug use, occasional alcohol use, and no use of tobacco and smoking. In her occupational history, she was intern in a company, and I stopped there.
Absolutely amazing. I think watch Riku, who doesn't practice medicine in English and Japanese, presenting in English so clearly. That's awesome, Riku. Thank you. And a very, very
Thank
interesting
you.
story. Yeah, Julia, what happened to your thinking?
Yeah, now I think that with this HPI, despite medical history, my diagnosis turned broad because I am thinking still something infectious right now. The first thing that I was thinking about is if I am thinking about a viral infection, maybe I can consider HIV because of this social history, the white patches on the throat. Other than that, arboviruses because of the rash. And thinking about bacterial infection, I would consider gonococcal as well as um, all of the diseases that can be affected, be affect the joint and the throat, for example, streptococci or anything that can cause all of those symptoms. So I would consult all of that. I would ask for an HIV test, blood culture, and make sure that this patient is breathing well. Because I think that with the painful swallowing, the patient can have like a bad, severe upper respiratory problem. So, but other than that, I would consider autoimmune disease, inflammatory reactions, and yeah, I'm with that in mind right now. What about you, Ravi?
Yeah, I'm right there with you. I think if you ask yourself, Julia, if you're seeing this patient, you probably have too many diagnostic hypotheses that you would not be able to act all of them in right now. So you kind of have to have a tiered sequential approach to what the diagnoses are. And I think uh, uh, putting yourself in a realistic situation, you ask yourself, what diagnoses do you need to think about or consider in the next hour? Because I think your analysis is very, very shrewd in that it is comprehensive. The tension in a case like this is what is your filter for diagnoses that need to be established in the next hour or two? So if you make this case simpler in that way, what do you think would be a shorter list for no misdiagnosis in the near future?
I think that the first thing we should address is the respiratory symptom
Perfect.
and make sure that this patient is saturating well, is breathing, and be prepared for maybe an intubation.
Yeah, I completely agree. I think that airway is probably the biggest risk issue here. And I think there's a small list of really serious bacterial infections that can present in this manner. So I think airway management will be sort of supportive regardless of the diagnosis. But you can see that when people present with a systemic syndrome that is centered around the oropharynx, uh, that combination of things is relatively unusual. Most people who have a pharyngeal syndrome that is serious and life-threatening disproportionately develop local complications, like a peritonsillar abscess or a retropharyngeal abscess or Lemierre syndrome or Ludwig's angina. The process tends to take up space locally and cause havoc locally. And so if you ask yourself, what are the things that are common to have pharyngitis and a systemic syndrome? They're usually not things that take up space locally, but rather viral processes. So I'm sure odds are in your life you've had a really bad pharyngitis and felt very, very poorly systemically, right? From the flu or COVID. And then there's a subset of infections that are sexually transmitted that do this, like or sexually transmitted or human to human transmitted, like mononucleosis or HIV. Diagnosing HIV is important as an example, but it's not going to be life-threatening the next hour or so. So you're asking yourself, what are the bacterial infections that instead of taking up a lot of local space, disseminate to the rest of the body? And it really is, I think, fundamentally some of the bugs that you mentioned, and the your clue will be the rash. So, is the rash a non-specific maculopapular rash, which would reinforce your hypotheses about viruses? Or does the rash evoke the fingerprints of a bacterial process? So, for example, if she has rash is purpura, when somebody, a young person, has pharyngitis, fever, purpuric rash, this is Neisseria meningitidis until proven otherwise. So, what's the advice I can share? Most of the time, when you have a serious pharyngeal process, the seriousness is manifest by taking up anatomical space in a very serious area. When you have pharyngeal in a systemic process, you often have much more time to figure it out. And because it's usually a virus or some autoimmune diseases or maybe even some cancers, but none of those things are life-threatening. In a case like this, you have a very rare but realistic possibility of a small subset of really serious bacterial infections. And so your insight into that very small but life-threatening possibility is the nature of the rash. And so what I'm most interested in is what this rash will look like because it's going to take me a lot of time to understand the ankle arthritis, tap it, not tap it. That's going to take 2 hours. The one look at the rash will make me realize, oh, maculopapular, no worries, or ooh, this is no good. So yeah, I'd be very, very curious to see what we see when we actually look at her. All right, Rico, Mike to you, my friend.
Okay. So, I go to next. For her vitals, her temperature was 37.0 Celsius, and her blood pressure was 118, 18 over 80, and her pulse rate was 108, and SpO2 was 97% with room air, and her BMI was 21. And for physical exam, in general, she was in distress due to fever and pain. And her oral cavity exam was erythematous pharynx with mild swelling and no white patches. And lymph nodes was are palpated, no pain on palpation. And cardiovascular wise, um, S1 is too hard, no murmurs or gallops. And respiratory wise, bilateral air entry was normal. And her abdomen was soft, non-tender, without rebound or girding. And musculoskeletal skeletal wise, right and left ankle was marked with swelling and wounds and severe tenderness. Um, uh, yes, she had wounds and severe tenderness, and she also had a limited range of motion because of that severe tenderness and mild pain in both knees. Um, and I can share you a picture of the scan, but uh, should I put the button of share? Is it okay? Okay, let me show you the picture. Um, okay. So can you see this? So this was actually her legs will look like, those rush, and you can also tell the her ankles were swelling with tenderness. Okay. And um and also let me share some okay. So about the rush, she had a multiple non-blanching rushes were seen and no rushes elsewhere. And let me share some labs. Her CBC white blood cell was 10.4 and leukocytes was 14% and neutrophils were was 78% and eosinophils was 0.5% and her hemoglobin was 13.6 and her platelet was 206 and her creatinine was zero point 0.6 and BUN was 9 and sodium was 140 and potassium was 3.7. Clo was 106. AST/LT was 16 and 7 and alphos was 35 and her total bilirubin was 0.37 and her albumin was 3.8 and I stopped there.
Wow, I think Julia, we got a lot of information. And I wonder, it's a little bit early, but I think it's a great time to do a breakout room for people to share your thoughts and maybe share your thoughts with your colleagues. How does that sound to you?
Sounds great.
Awesome. Alrighty, I'll make a breakout rooms and we'll see you all in a few minutes. All right, welcome back, everybody. So, Julia, what do you think?
Yeah, so we were discussing about the possibilities is still about a bacterial infection going on, especially because of the physical exam showing swelling and edema on the ankles, these erythematous pharynx. So we would discussion about the possibility of gonococcal infection going on. The rash is nothing that is concerning because we were expecting a more severe thing going on. And about the labs, the white blood cell count seems to be like a little elevated and with a neutrophilic pattern, which strong that thing. Another possibility is like acute rheumatic fever, HIV, or maybe vasculitis going on because of the rash on the lower extremity, and this patient is young. So the discussion was about all of that. And I think the priority right now will be like
Mhm.
blood culture,
Mhm.
make sure still this patient is breathing well, and maybe in the future, in the next few hours, try to aspirate
Mhm.
a fluid of the joint.
Mhm. I think that's absolutely superb. I'm right there with your same diagnostic hypotheses. So it sounds like the next thing that we would do is get blood cultures and try to do an arthrocentesis. Um, any other tests that you're trying to collect in the first few hours or so? What do you think?
Mm, chest X-ray, I guess,
Yeah. How are you thinking about what data to collect from the pharynx for where she's hurting? What do you think you would get from there?
from the pharynx.
Yeah.
Yeah, we should do a swab.
Yeah. Yeah,
Hmm.
I think in a case like this, the number of diagnostic possibilities is quite high. But I would say the main issue is her ankles. Because as you said, her rash isn't so bad, her pharynx isn't impending. But every moment that goes by with her having potentially a septic arthritis is a moment where her cartilage is being eaten up and that she could lose the ability to walk. So I would say what part of this case is urgent? It really is her arthritis. And she seems to have really an oligoarthritis where she has a small number of joints swollen in an asymmetric fashion. And so if we ask ourselves, what is the differential diagnosis of oligoarthritis? Um, it, it really borrows mostly from the differential diagnosis of monoarthritis, where infection looms large. In older people, oligoarthritis is most commonly caused by crystalline disease, but that is not a wise diagnostic investment in younger people who tend not to have crystalline disease. So instead of crystalline disease, the major non-infectious cause of oligoarthritis in younger people are the range of diagnoses that live under a spondyloarthropathy. And so reactive arthritis is the most acute version of that. Um, and so I think if you are asking yourself, are you ready to diagnose a reactive arthritis? And the answer is no. And by far and away, the most common cause of an acute infectious arthritis in a young person is disseminated gonococcal infection. And this is a really powerful point in clinical reasoning where as soon as a case turns into nothing but must rule out blank. So there are cases of chest pain in the ER where must rule out ACS, or cases of thrombocytopenia with altered mental status must rule out TTP. And you notice that frontline providers stop thinking about the case as a whole because they find themselves in a rare situation where there's a really serious possibility, and only after exonerating that possibility do you move on. The good news is all these possibilities I just mentioned are rapidly exonerated or empirically treated. So the question for you, Julia, is what do you think about empiric treatment? Uh, when would you, is your threshold for disseminated gonococcal infection right now high enough that you would empirically treat, or would you wait? What do you think?
I think we can treat.
Yeah, I think I will treat, of course, because the severity of
Yeah.
the disseminated gonococcal infection is very strong. So I would make sure that this patient is receiving antibiotics as soon as
Right,
possible.
right. Absolutely. The only downside of empiric treatment in general is the reduction of diagnostic yield. So, if you are going to empirically treat, you have to ask yourself, does that reduce your chances of a diagnosis? You can get a lot of tests very quickly, like blood cultures and a pharyngeal swab, that will not slow your empiric treatment down. But the real life question is, do you do empiric treatment before or after arthrocentesis? And I think that's a difficult decision. And the learning about that comes from the realization that the microbiological yield of an arthrocentesis in disseminated gonococcal infection is actually very low. The most common place where you isolate the organism is where it all began, at the site of mucosal exposure. So, in this situation, if I was experiencing difficulty finding a good place to remove fluid from her knee, I would empirically treat her. So, here's what I would try. I would do blood cultures, pharyngeal swab, diagnostic testing for HIV, syphilis, everything you said. And I would order the ceftriaxone, 2 grams IV. I would ask the nurse to hang it and be ready to give it, but I would try for maybe 5 minutes to remove the fluid from her ankle. If I wasn't able to do so, I would just go ahead and give the medication. That's realistically what I would do. Now, it may be that we sample her fluid and we get all the data and we completely hop off this disseminated gonorrhea train. And if the final diagnosis has nothing to do with this hypothesis, I still think the journey to whatever that diagnosis is, be it IgA vasculitis, Still's disease, has to take a very pregnant, deep pause to exclude this life-threatening or limb-threatening diagnosis. So let's see what Rico has in store for us.
Wow, that was stunning. Um, so let me do next aliquot. Uh, Maybe I can answer almost all of the your questions in this aliquot. So in urinary analysis, it was within normal limit. and her PT was 10.6, APTT was 27, and her INL was 0.96, and D-dimer was 1.1. And I did her throat rapid streptococcal test. It was positive, and ESL was 28, and CLP was 3.6, which was mildly elevated. And I did blood cultures, and it was negative, and her EKG was normal, and her chest X-ray was normal, and we did a CAT scan of abdomen and pelvis, which was normal, and uh, I tried to do arthrocentesis, but no effusions at the bilateral ankles and on pulcus. And ankle pain persisted and was treated conservatively. Actually, I gave her ceftriaxone, but mainly treated conservatively. And after 4 days, ankle pain and swelling resolved, and I stopped there.
Very interesting, Riku. Thank you so much. Julia, what are you thinking with all this interesting data?
Yeah, that's very interesting. Um, First of all, the labs, there's nothing concern for me. Just like the inflammatory markers, yes, R and CRP a little bit elevated, but other than that, there's everything okay. The rapid strep test is positive, but
Hmm.
I'm not sure if that is the cause of the problem. With that being positive, I was thinking about acute rheumatic fever,
Hmm.
but I am not excluding gonococcal infection. So, the blood culture was negative, but I will repeat that, I think. And yeah, but this
Excellent.
patient had a ankle pain resolved. And did this patient receive it corticosteroids or something like that, Riku?
In my memory, we didn't gave her that kind of corticosteroids or something.
Okay.
But yeah, only in analgesics and ceftriaxone.
Yeah.
Okay. Yeah, so the ceftriaxone was given and the patient had the improvement of the symptoms. So I'm not sure, Ravi, how to go
Yeah.
for that.
Julia, you're making your discussion is so cool, calm, logical, and I think you made an enormous leap. Because if I'm a junior medical student, I am asking the question, how is this case not solved by the positive rapid strep test? And you're right, it's not. But maybe you can explain your thinking about why you are not fully committed to that being the key diagnostic test. What is behind your thinking there?
Because this patient had a lot of things going on, and with the rapid strep test being positive, I don't know, it's just like does
Yeah.
not answer all of the questions for
Yeah.
at least for me.
Perfect. Let me ask you a fun question. What if instead Riku said not rapid strep, but gonorrhea PCR positive? Would the case be solved?
Yeah, I guess. Yeah, I think
Yeah.
so.
So what do you think the difference between the two is? Because you're right. Why does that make you happy and this makes you anxious?
Yeah, because with the gonorrhea like
Yeah.
being positive, that will explain the
Right.
throat, the
Right.
arthritis,
Right.
the rash. But with the rapid strep test being positive, that would not explain. And maybe that should be concerned for a more severe like
Good.
course.
Very good. Yesterday I was working in the ER and I had a patient who had URI symptoms. I sent some tests, The nurse comes back and says, "Oh my gosh, his blood culture is positive." And I said, "What?" And it turned out the nurse was telling me about the wrong patient. And what fundamentally is happening is you have to ask yourself, what is the compatibility of this syndrome in front of you with the test that you're receiving? And there are some tests that are so specific that no matter what syndrome you have, you're going to move in that direction. The reason that a rapid A strep does not have a perfect specificity is because it is a common colonizer. And we have 28 people on this call. If you have, statistically speaking, swabbed all of everyone, hopefully everyone is feeling great, you will catch group A strep positivity in 1/3 of people. So the group A strep throat swab is a non-specific test and is only valuable when the pre-test probability is high. This fact is the very basis of the Centaur score, which only tells you to test for this bug in a very specific context. And the reason for testing it in a very specific context is because outside that context, the specificity plummets. So now we have to ask ourselves, is this the right context? And the answer is not completely. This case could be a case of acute rheumatic fever. This case could be a case of what's called post-streptococcal reactive arthritis. But the nature of the rash and the hectic presentation makes it really important to exclude the most important mimickers. And I think the most important mimicker here is disseminated gonococcal infection. So I think that the value of this strep test is it gives you an alternate diagnosis, which portends a pathway to clarity, but only after you've excluded the mimicker. So we could end up diagnosing her with rheumatic fever. And the way we might do that is we might get an EKG to see some changes. We might get an echo to see some valvular changes. But I think the test that we would all want before that is to make sure she doesn't have HIV, doesn't have syphilis, but most importantly, because of the purpuric rash and arthritis, that she doesn't have disseminated gonococcal infection. Otherwise, we're going to have to give her ceftriaxone forever until we figure out what's going on. So that was a very shrewd analysis to not latch on to that strep fully. All right, shall we hear from you, Rico? What do you have next? Rico, what do you have next?
Okay. Let me go to next quad. So her IgA was 183, which was normal, and her IgZ was 1044 44, which was normal, and ANA was negative, rheumatoid factor was negative, PL3 ANCA was negative, and MPO ANCA was negative. CH50 was normal. C3 was 161, which was slightly elevated, and her C4 was 38, which was slightly elevated. And her chlamydia and gonorrhea was negative, and also negative for syphilis. And her TEE was no effusions, no visitations. And I stopped there.
All right, Julia. We finally had the test we've been waiting for. What do you think now?
Well, no, that's very interesting, but I think that I'm more confused. Yeah, the tests are all negative, and the CT and C3 and C4 are a little bit elevated. So I'm not sure, maybe like a concert vasculitis, but all of the ANCA, ANA, rheumatoid factors are negative. I'm very confused, Robbie, help me.
Yeah, I feel you. I totally get it. I think that it's a good kind of confusion, right? Because all the scary things are negative and she's feeling better, right? So you ask yourself, just be practical in a moment. You have a patient whose problems you have fixed. She's happy, and all the tests of the scary things are negative. So you ask yourself, what are you left with now? And I think the only dilemma you have is how long you give her ceftriaxone or antibiotics. And that's way better, right? So the question is, what happened to her? And I think now you probably have to generate some hypotheses based on the only test you have positive, which is that she has a rapid strep positivity. So just take a moment to say, okay, now that she's safe and fine and better, and all the scary things have been exonerated, um, just maybe minus the HIV test, um, what do you think what hypotheses can you generate with her positive strep test? What do you think?
Um, since she's better and everything is negative, I would think that this was like a maybe a reactive arthritis that
Mhm.
happened and just pass it.
Good. Yeah, very good. I'm in that same. Oh, oh my gosh. Good morning, Caroline. I'm in. Kara's feeling under the weather and is causing some chaos in the other room. Hopefully, it's not too loud for you all. I think that the progress that I can try to make with you, Julia, is to go back to the POCUS. So remember when Riku said, "Hey, when I did a POCUS, I did not see an effusion, and yet her ankle is angry." And I would love for you to try to think that through. Why would somebody's ankle be angry without an effusion? What do you think?
Good question.
Oh, thank you.
Um, without an effusion, I'm not sure if like an inflammation there would not cause an effusion. Like if there's inflammation, but the inflammation is not like dealing with an infusion. So yeah, I'm not sure, Ravi.
Yeah, I think that you're essentially saying either she has mild inflammation in her synovium.
Uh-huh.
The most common reason for a joint to swell up, as you saw, without our synovitis is they have tenosynovitis, tendon involvement. So I would say that once Riku showed us the POCUS without arthritis, this problem becomes that she has acute tenosynovitis of the tendons in her ankle joint. And what does that problem representation, what hypotheses does that generate for you? Tenosynovitis.
Tenosynovitis in this patient. Mm.
Maybe just in general so that you can practice. If you see tenosynovitis full stop, no other details, what thoughts do you think about?
Yeah, the first thing that I would think about is if this patient, I'm curious to know about the activity of this patient, if this patient is like having a lot of it's using the tendons a lot,
Very
so is making a lot of exercise
good.
that is stressing that tendon and making it inflammate.
Mhm. Very good. Yeah, use-related tenosynovitis is by far and away the most common. Odds are you and I have already experienced that. When it comes to inflammatory tenosynovitis, infections are the most morbid hypotheses, and they're the same ones we talked about. Staph, strep, and gonorrhea. And when we're talking about staph and strep, we're talking about direct infection of the tendon. Um, uh, so those things have been made less likely by her course and her improvement. In terms of autoimmune tenosynovitis, in older adults, it's crystalline disease again because the crystals deposit around the tendon, they can inflame the tendon. In younger people, it's the same diagnoses you've already mentioned. It's the spondyloarthritis, namely reactive arthritis. However, the whole in these is her purpuric rash. And so I will share with you the really interesting hypothesis of IgA vasculitis. So IgA vasculitis classically causes a post-infectious purpuric rash, but has a large amount of musculoskeletal manifestations, including arthritis and tenosynovitis. So, what are we trying to accomplish here? What we are really are trying to accomplish is to help this patient understand what her risk is of this happening again. Because we're going to treat her for strep and she's going to get a penicillin or amoxicillin. The question for her is, what is happening inside her body that made her react in such an angry way? And I think the one next step is to biopsy that purpura and to see what that rash is about. And I think I would give her maybe 20 or 30% chance of having IgA deposition because a post-infectious purpuric rash with arthritis is very, very suggestive of IgA disease. IgA nephropathy and vasculitis have a tropism to affect people in the Pacific Rim, which includes Japan. So I think that would be the hypothesis. And what does that mean? That means that every time she might get a mucosal infection, she might not react very well. It also might mean that her kidneys may accumulate damage if she has this tropism. So uh, uh, what are we? We're out of the risky range now, and we're just trying to make sure that her future is as healthy as it can be. All right, Riku, what did you all do? What were you all thinking?
Wow. That was such amazing discussion. Shall we go to next, Alquoit?
Yes, please. Oh my gosh.
Okay, the last one. Um, so on second day of the admission, we did the skin biopsy, like as you said. And her skin biopsy revealed leukocytic vasculitis with IgA deposition. So that was the last Alquoit. And next, I reveal the diagnosis.
Julia, I told you Riku is a friend of mine, and maybe he changed the result to to fit the discussion. Everyone watching on YouTube is almost sure that I paid Riku $5 for this.
That's too cheap.
Yeah, but thank you,
Wow.
Riku. I'm curious to get your thoughts in one moment. Julia, what are you thinking? What did you learn in this case?
Yeah, very interesting case. I was not expecting that the case started with like something and then completely changed, but you were right, Ravi, as always. I learned a lot about this case, so people purpura, of course, think about vasculitis, especially in young females. And like in these cases of infection that we rule out everything, consider vasculitis. So that's my learning from today.
Yeah, my biggest takeaway, Julia, is just watching you being so um so measured in your thinking. When if you watch your discussion again, which I recommend you do just to show you how far you've come along, your initial diagnosis was so broad. And you already were considering autoimmune diseases from the first aliquot. But I think what we are trying to teach everybody is the journey towards a successful diagnosis of autoimmunity requires very thoughtful consideration of infections. And I think nobody will diagnose this condition with the same data if the gonorrhea is pending, because gonorrhea is to an infection. And all that we're saying in her, this diagnosis, what does it mean? It means she has an abnormal immune response. Something, in this case, thankfully, just strep. But it easily could have been disseminated gonococcal infection complicated by IgA vasculitis. So the IgA vasculitis is just her reaction. All of us react differently to infections. Right now, Kara and I have probably the same virus from our cruise. She is having way more symptoms here, and I'm having way more symptoms here. This is reaction. And for some people, their reaction is pathologic. So all we know is her immune system, unfortunately, will likely react pathologically in the future. But it's still really important every single time she reacts to ask, what is she reacting to? And does that infection independently do damage by itself? So the fact that you took such a thoughtful pause and really fixated on DGI is, I think, the biggest takeaway in this case. Um, and yeah, I'm very, very grateful for it. I thought you were absolutely outstanding. Um, so kudos to you. What about you, Rico? What did you learn from this case?
Well, Yeah, this case was I saw her at the night shift at the emergency department only by myself, and I was really worrying about her symptoms because she could not, she barely walk by herself, and the symptom itself was a little bit straightforward because she only had pharyngitis and pubic purpura. So, but uh, we really encounter IC vasculitis at such an acute stage. And to be honest, I was not aware that streptococcal infection could act as such a trigger for IgA vasculitis. So the symptom itself was simple, but it made me think a broad differential diagnosis like um, infective endocarditis and also gonococcal infection, reactive arthritis. So I learned a lot from this case. So I thought this would be a good case to share. So.
Yeah, thank you so much. I think it's the most poorly kept secret that we were waiting for you to finally get your first ca case presentation before bringing you and inviting you into the academy. So I'll say that publicly. I'm very excited for to keep learning from you and to yeah, the way that you told. I can't imagine what it would be like for me to present a case in Japanese. You know, your grasp of medicine and your grasp of storytelling is unreal to be able to put the story together in English. So yeah, well, thank you for an awesome, awesome hour.
I
Uh,
always learn from this critical problem solvers. So
yeah,
I wanted to say thank you for
for
this
sure.
opportunity and
Absolutely.
everything.
Absolutely. Thank you so much, Manaswini, for scribing. Manaswini hung out in the breakout rooms and like was making the board as amazing as it is now. Mike, to you, Aaron, you want to take it away.
All right. Thank you so much for the interesting case, Riku. I learned a lot this morning. So, to start with, we had our female with the fever and painful swallowing and bilateral ankle swelling. The approach to the painful swelling, we were considering oral ulcers, pharyngitis, and large lymphadenopathy. And most importantly, we had to rule out any risks for airway compromise. For the pharyngeal syndromes, most we know are presenting with local complications, such as tonsillar abscess, retropharyngeal abscess, Lemierre's, and Ludwig's. But other systemic pharyngeal syndromes include common viral infections like mono, HIV, and also bacterial such as Neisseria meningitidis. Eventually, when we got to the physical exam, the patient was presenting with very swollen and warm bilateral ankles with tenderness. So in the elderly, you would think of crystalline disease as the cause of this, but in younger patients, we think more of spondyloarthropathies such as reactive arthritis and disseminated gonococcal infection. We also had a tension point of empirically treating this patient with antibiotics and if this would reduce the diagnostic yield, but not really for this patient with the joint tap, which we were unable to tap anything. When we did get our positive rapid strep, we had more tension there as strep is a non-specific, well, the rapid strep is a non-specific test, and it's valuable only in specific contexts, such as those that are included in the Centaur score. But this positive strep test could still suggest post-strep reactive arthritis or acute rheumatic fever, for which we had further workup, which was otherwise negative and unrevealing. We also had our GC chlamydia syphilis negative, and our room workup was also negative. A TE was also negative. Ultimately, we had a skin biopsy revealing the diagnosis of leuko, which showed leukocytoclastic vasculitis with IgA deposition, which we found out is consistent with IgA vasculitis. And yeah,
Aaron, check out Sarah's comment. I love this TV board format. She's gonna steal it from you. Yeah, this case was a kind of a twisty journey, and I think you outlined every single branch point with so much clarity and precision. That was absolutely awesome. Thank you so much, guys. I missed you all. It's cool to be back, and thank you again, Rico, for a really cool case and a great discussion, Julia. Hope you have a great rest of your day.